Now we call upon is also here, Dr. Kirthi Reddy. You are there.
Good evening, everyone. I am representing on transcutaneous retrobulbar amphibiation B in post-COVID-19 ROCM. So, ROCM has been a relatively rare disease, and it reached epidemic proportion in India during the second wave of COVID-19 pandemic, and a deluge of cases were reported. So the dilemma arises when there is involvement of orbit and the removal of the eye, that is exenteration. They cause significant psychosocial problems, and there has to be a close balance when we are preserving the eye and preventing further intracranial spread. So the delay may sometimes lead to fatal outcomes. So the desperate times needed desperate measures, and we resorted to transcutaneous retrobulbar amphotericin B. So the case series, there have been isolated case series and case reports which have highlighted the use of tram, but there was no consensus regarding its use in invasive ROCM. So this was in pre-COVID era. So the aim was to assess the effect of tram on clinical course of ROCM in terms of alleviating the need for exenteration, post-retrobulbar BCVA, proptosis, extraocular movements, ptosis, and intracranial spread or worsening of the disease, and complications post-tram. So it was a prospective intervention study undertaken at a dedicated tertiary care COVID-19 facility ranging from 29th of May to 31st of July. The previous studies have taken only limited orbital diseases, but when we had our inclusion criteria, we included all the patients with stage 3 ROCM, and patients awaiting exenterations in cases of extensive orbital involvement were also included. The patients with extensive intracranial involvement were excluded, and obviously the patient who did not consent were excluded. So the following variables were studied, and the failure of the tram was defined as worsening of the disease staging or intracranial spread. So the patient admitted were given transcutaneous liposomal amphotericin B alternate day till the patient underwent debulking surgery, endoscopic or open, and it was resumed from second post-op day alternatively till patient showed clinical stabilization or improvement, whichever was earlier. So the quadrant was chosen and guided by the clinical findings and the radiological findings. There's a video showing how we proceeded to give the tram. So 45 eyes of 41 patients were included in the study, and this was the stage-wise distribution of the patients. Majority of the patients were in stage 3 ROCM. The median number of injection given was 6, and the minimum and the maximum number of injection were 3 and 8 respectively. Approximately 65% of the patient had improvement in proptosis, 59% had improvement in ptosis, 15% showed a minimal improvement in extraocular movements, but none of the patient had complete recovery. 17 patient presented with PL negative eye, and only 6 showed improvement in BCVA. So this is a minimal improvement in ptosis, and this patient shows improvement in extraocular movements. So 4 eyes ultimately underwent exenteration, and out of these 4, 3 had presented with ophthalmic artery occlusion, and despite repeated tram, they underwent exenteration. 1 patient developed a stage 3 post debulking surgery. None of the patient had extension, intracranial extension or worsening of the disease process, and 5% of the patient had transient post-tram complications like chemosis and slight redness. Previous literature have already supported the use of tram in limited orbital diseases in ROCM. All the 9 patients with limited orbital disease, which were stage 3 and 3B, had a good improvement in all the clinical parameters. They also needed less number of injections. So this was a This was a pre-COVID paper which had supported retrobulbar amphotericin B. These were some of the papers which supported the use in post-COVID-19 ROCM. Patients with not so limited diseases none of them had complete recovery in proptosis, ptosis, and extraocular movements. 25% of the patient having ophthalmic artery occlusion, they underwent orbital exenteration, probably due to orbital infarction syndrome. 6 patients had improvement in vision. Resolution of proptosis, ptosis, and extraocular movements were not complete, but the need for exenteration was alleviated in at least 75% of the blind eye, resulting in an anatomically preserved eye. So the TRAM basically helped us buy time in cases needing exenteration, and sudden surge in ROCM cases had led to long waiting list of patients needing surgical interventions. None of the patients undergoing TRAM injection had intracranial extensions. So to conclude, early intervention with TRAM does have subjective and objective improvement. Its judicious use can help us bring down the morbidity in these cases and also reduces the need for exenteration and help us buy time. So there has been a selection bias in these patients, and the staging was which was followed was a comparatively recent proposed classification. Thank you.
Thank you. How many cases were there in your study? I missed out.
Sir, 45 patients and 41 patients with 45 eyes.